And Tom Montine.
Thank you, Eric. Thank you, Linda. Good afternoon, everyone. I would like, in my prepared comments, to give you an overview of brain aging. First, an idea of its clinical complexity, then its biological complexity, and then my final comments, at least in my opinion, how we can bring some clarity to this complexity. So first, clinical complexity. Aging brain is vulnerable to three prevalent chronic diseases: Alzheimer's disease, Parkinson's disease, or if you prefer more broadly, the Lewy body, the spectrum of Lewy body diseases, and vascular brain injury, and in particular, small vessel injury to brain, the same type of small vessel vasculopathy that produces nephrosclerosis, heart failure, it damages the retina. The brain is also an end organ for this type of injury. In fact, it's quite common in individuals who are 70 years or older. So Alzheimer's disease, Parkinson's disease, vascular brain injury, they're each chronic diseases, so they each have a latent phase before their clinical expression. Their clinical expression, at least as they affect the brain, begins first with difficulties thinking, so problems in one or more cognitive domains, and then that progresses to the full expression of disease dementia, in which the cognitive impairments are much more profound, pervasive, and lead to impairments in activities of daily living. Importantly, the evidence from across the globe, individuals who are impaired most commonly have evidence of two or more of these diseases in brain. Importantly, even those individuals who are not cognitively impaired commonly have evidence of two or more of these diseases, less commonly one disease. And what's actually uncommon in individuals 70 or older is to have no evidence of any of these diseases. By estimates throughout the United States and Europe, it's less than 10% of this older population will have no evidence of any of these diseases, despite being cognitively intact. So when we consider the clinical aspects of aging brain, there are two facts that complicate the story. First is that comorbidity is the rule, not the exception. And the second is that latency of these three diseases, latency is highly prevalent in the population. So then to the biological complexity. Somehow the biology of aging is permissive for these three diseases, right? Because these are, quote, age-related diseases. And we've heard so far today about multiple mechanisms that underlie the biology of aging that may be responsible for this permissiveness. We just heard about access to energy earlier, telomere shortening. We heard briefly about oxidative injury. In the keynote talk this morning, the idea of reduced trophism, and then, of course, endocrine senescence. These and likely others alone and in combination contribute to this fertile soil for neurodegenerative diseases. As was hinted at this morning, as best we can tell, the molecular drivers for neurodegenerative diseases, and as gleaned from genetic risk, those molecular drivers are largely distinct from what we think is driving the biology of aging. And the mechanisms then of neurodegeneration are different from the list I just gave you. So they include overproduction or reduced clearance of toxic protein aggregates like amyloid beta or alpha-synuclein, disruption of the neuronal cytoskeleton and transmission of toxic species between neurons, for example, pathologic forms of tau. And I'll pause there for a moment and say an inductee of the National Academy of Medicine in the 2014 class, Dr. Brad Hyman, is the one who pioneered that work. Other mechanisms, altered autophagy and synaptic vesicle recycling. And then another that's gaining prominence is activation of neuroinflammation. So there are mechanisms that underlie the biology of aging. They partly overlap but are largely distinct from what we think are the molecular mechanisms that are driving neurodegeneration, and both are further complicated by an individual's interaction with the environment. So in summary, what we call aging brain is in reality an environment in which the processes of aging interact with some idiosyncratic mixture of latent neurodegenerative diseases. And those neurodegenerative diseases have different molecular drivers. So the short summary of this is that no two aging brains are the same. Right? Trivial. So how do we bring clarity to this clinical and biological complexity? Well, at least for the diseases that commonly injure aging brain, in my opinion, the approach of precision medicine now has wide currency in advancing cancer care is likely the best approach to the aging brain. So the key aspects of this are stratification of risk at middle age or earlier, and then based on that risk, graded surveillance for preclinical disease. And then I'll pause and say both those arenas were having some success in the research setting, not yet translated to general medical practice. The third step, since Al asked about gaps, the third step is developing disease-modifying therapies for neurodegenerative diseases. We don't have those yet. And we need not just one, there won't be a magic bullet, but multiple ones tailored to the different molecular drivers of neurodegeneration. I'll just mention in closing that there are now clinical trials that embrace this perspective. I'll mention them briefly because I suspect my colleagues will discuss them. The Dominantly Inhabited Alzheimer's Network Trial Unit run by Randy Bateman, the Alzheimer's Prevention Initiative run by Eric Ryman, and the anti-amyloid A4 trial run by Risa Sperling. These all embrace this idea of genetic risk stratification with agents directed at specific molecular drivers. So in summary, aging brain, biological complexity underlies further clinical complexity that we hope soon will yield to these tools of precision medicine. So thank you very much.